Now I pivot to this right here. So it's perfect time. It's 7:31. We're about a minute behind the schedule. So I am going to ask Lina to say a few words, and then we're going to get to Dr. Akinduro. Lina, take it away.
Yes, sir. It is my absolute pleasure to introduce Dr. Akinduro. Dr. Akinduro obtained his bachelor's degree in biology and chemistry from the University of Alabama at Birmingham, where he then proceeded to work as a chemist for a pharmaceutical company a year after college graduation, prior to obtaining his medical degree from Morehouse School of Medicine. Dr. Akinduro is a stellar neurosurgical resident. He completed his in-folded fellowship in neurosurgical oncology under the mentorship of Dr. Q. He has been recognized with several honors and awards for his translational work, most recently with the prestigious NREF and AANS CNS section on Tumors Research Fellowship Grant. Next slide, please. Additionally, he has made a significant contribution to literature, over 46 publications, 402 citations, and an H index of 10. Next slide, please. And this is just an overview of his contributions.
Beautiful. Thank you, Lina. This is great. And at a personal level, of course, it's an absolute pleasure to have Olu, who is not only a great resident, a great colleague, a gifted resident, actually, a great colleague, caring physician, but also a great father, a great husband, a great friend, and someone who, you know, we all enjoy working with. Everybody here knows that he is scheduled after this year to go and spend a year. He's been very interested in spine oncology. And we wanted to, a lot of you guys are already doing spine oncology, but to take spine oncology to the next level, we needed someone who's going to be dedicated, passionate, who's going to have not only the clinical expertise, but also laboratory experience to be able to start and run a laboratory. So when Olu was coming to the lab, he knew we were interested in chordomas, which is at the skull base, you know, and we were interested in meds to the brain because of work that Kai has been doing. So he decided, why don't I take that work to the next level and really begin to focus a lot of our work on the spine. And that's exactly what he's done, with the ability to then go to Ziago Kaslan, who's considered the leader in spine oncology in the world at Brown. And then for that, he was awarded a Mayo scholarship, which is a big deal at the Mayo Clinic. And then he comes back, you know, after his year with Zia to continue his work. Hopefully by that time, we will have an hour one. This work that he's doing, and we stand on the shoulders of giants, began many, many years ago by Sagar and Juan Carlos. Juan Carlos is actually a resident now in Texas. And they began to do a lot of work. We applied for an hour one, we didn't get it, but now with Olu's help and expertise and data that he and Paola and many other team members, Paula, have gathered, you know, we're going to go ahead and resubmit that. So having said that, I'm going to stop right here, Olu, and I'm going to let you share. You should be a co-host right now. We're looking forward to your many contributions, and also we're looking forward to seeing your family also expand, because I know that you may have some news about that. I think that you're muted, Olu, so that just maybe see if you can unmute yourself.
Okay. Can you hear me now?
Yes, now we can hear you. You were muted there for a little bit.
Let's see if I can put this on presenter view.
Yes. Perfect.
Okay.
Now we see the presenter view.
Perfect. All right. Well, thank you, Lena. Thank you, Dr. Q. I'll send you guys a check in the mail. That was much kinder introduction than I deserve. So yeah, I'm excited to talk to you guys about some of the work I've done. The work I'm talking about now is really over the last probably 8 months. But of course, there's a lot of, you know, work that went before this, and a lot of data that Dr. Q mentioned was collected before, and even some of the work I, you know, kind of collected. I'll kind of touch on that, but this one I'm going to be focusing on just chordomas and how I'm trying to make them more sensitive to different treatments. So I'm here, I'm on call this week with the team, but I'm excited to talk to you guys about this. So just a quick background, chordoma, as we all know, Dr. Q, you know, primarily deals with it in the skull base, but then it's also found in the spine, and it's considered the most common malignant primary tumor, but I put malignant in quotes because it's technically histopathologically benign, but it has very aggressive features. It's well known to be locally invasive. It typically involves and invades all the surrounding structures, and also can have mets, which you typically don't see in benign tumors, which is why I said, once again, it's typically considered malignant. There you can see the incidence, 0.08 per 100,000, most common in men and at about 50 to 60 years of age. And as you can see, a pretty low 10-year and 20-year survival. So the thing about chordoma, it's extremely resistant to therapy. You basically have to treat it with high dose proton-based radiotherapy. That's kind of standard of care after surgery. And the goal is to get an en bloc resection where the margins are clean. And the issue is, if you don't get clean margins, there aren't really any chemotherapies that you can treat them with. There's nothing approved, no FDA approved chemotherapy. And like I said, it requires a high dose of radiation. And the issue with that, as we know, high dose radiation can affect the surrounding structures and place them at risk. Here, this is a paper we published about cervical cordomas, where, I mean, it's all prime time real estate. You have all these different structures in the neck. And even though these are high risk surgeries, our data shows that getting an en bloc resection, getting a complete resection is still standard of care, and is still much better for these patients than if you don't. And the reason for that is, like I said, you really don't have any other therapies. And I'm not in the military, but I always think, they say no man left behind, but in chordoma surgery, it's really no cell left behind, because these tumors, all it takes is one cell and they can replicate and form new tumors. It has a very high population of these cancer stem cells that have the ability to replicate themselves. That's one of the reasons why these tumors are so hard to treat. I mean, if you think about it, if you're doing skull-based resection through the nose, you have to be careful, even just pulling the tumor out through the nose, because even if you leave, I mean, there have been reports of, cells being found or cells being left behind in the nares even, and then those forming new tumors. So it's definitely a challenging type of tumor to treat for that specific reason. So this is some of the work that was done before me. Basically, the Brachiary YAP regulatory axis is, think of it as a master regulator or driver for tumorigenicity in these tumors, for stemness and growth. So Brachiary is upstream of YAP, and YAP itself has been studied for a plethora, tons of different tumors. There's a lot of work going into this right now for other tumor types. So a lot of the work I'm going to be talking about here can actually be applied to tons of other tumors, which makes it even more important. So the drug that I'm using is called Vertoporphin. It's FDA approved already for macular degeneration, which is great, which means that ideally it shouldn't be as difficult to get it approved for our indications. The way they use it is different from how we use it, though. It's considered photodynamic therapy. So if you give light at about a wavelength of 690, that can cause it to release free radicals. And that's the method by which it's used for macular degeneration. But for our use is how its effect on the YAP pathway. But the only issue with the drug, of course, is that it's highly hydrophobic. So the delivery modality, the delivery method we're using is that it can be released slowly from these particles. So I'm going to kind of get into some of that a little later on. And here the purpose of this is just to show that the mechanism of action is to block YAP-TEAD interactions. So YAP by itself cannot really do much of anything. It needs TEAD to bind to then cause transcription of all these various genes that enact all of its different effects on tumorigenicity, clonogenicity, migration, et cetera, et cetera. So here, kind of getting into some of the data. The purpose of this is just to show that Vertoporphin has an additive effect with radiation. So if you give Vertoporphin plus radiation, they work better together. And this is just an additive effect. So as you can see here, and also it doesn't take much. You can see here from the dose response curve, pretty low doses of radiation needed to enact these effects. And you can see from the strong leftward shift when you add radiation. So here, I thought this was pretty cool. This is basically showing that verteporfin not only has an additive effect with radiation, but it has a synergistic effect. And to prove that, there are a few different scores and a few different things that you can use. And this is something that was shown to me by Anna a few months ago. And thankfully she did, because this really is it's important, because like I said, not only is it additive, it's synergistic. And the ideal dose is 4 gray radiation and a really small dose of verteporfin, so only 0.25 was found to be the most synergistic dose. So here, this is cool. So Comet assays are a way to directly detect DNA double-stranded breaks. So here I'm going to show the actual effects of the radiation and how a verteporfin can kind of modulate the amounts of DNA double-stranded breaks that you're seeing. So also, if you see at the bottom here, this is just an experiment where we showed that the amount of DNA damage is greatest at 30 minutes. And the reason why that's important is because that's the time point that I used for all of these experiments. And comet assays, they're pretty cool because they really do look like comets, like shooting comets in the sky. So I always like to take these pictures of them. So,
and Olu, can I ask you a question? I know that you're going through a lot of data, amazing data, and tons of work that you have put to this. I'm going to ask you to pause right here so far, and I'm going to ask you to put it in perspective. So far, based on everything that you have shown, these are, tons of months of work, but even before you began to collect this data, you had to perfect a lot of the techniques, of course. But put it in perspective so far to where we are right now and the data that you have presented. What does it mean for for patients? What does it mean, for the field, the discoveries that you have shown so far?
Yeah. So as of right now, basically, we can say that if you give verteporfin to a patient with chordoma, before they receive radiation, it's going to make the radiation work much better, exponentially better. And obviously, like I mentioned, you typically need a high dose of radiation for chordoma because they're so resistant to it. So if you can have a situation where you can give this patient verteporfin either intraoperative or systemic before they get radiation, it should make the radiation work much better. So you can give them a lower dose, and the dose you give them is going to be much more effective than it would have been if you hadn't. So like I said, this work can be applied to tumors beyond just chordoma. So this can be potentially a game changer for, in the radiotherapy world.
Beautiful, beautiful. And then in regards to the technology that you're using, just put it in perspective. Not only the techniques like the Comet assay, but the nanoparticle technology, put it in perspective for people to get a sense of where that is going and how it will be relevant. You mentioned it already, but I wanted to see if we can give a perspective for people.
Yeah, so the microparticles, the main benefit in this situation is that the drug itself is poorly soluble. So you can have a situation where you can place it somewhere and it will stay there and just release slowly over time to allow it to be absorbed at the maximal amount possible. But this is really just like the first step, and a small step, I would say, because a lot of the plans, and I'll talk about this at the end of the talk as well, but the next step is to, of course, get this approved on the FDA level, and then even to find better ways to deliver and ways that can allow this drug to dissolve better in bone. So there's a lot of different things that are in the background that are going to be coming hopefully in the next few years. But definitely very exciting technology and things that haven't really been done for this pathology.
And one of the principles that Olu and I have talked about is, so far we have used mesenchymal stem cells as Trojan horses. That means that you hide stuff inside of the machinery, But can we think of mesenchymal stem cells as mules? If you look at a picture of a mule, the stuff is on the outside. Can those be able to be used to deliver, because they can migrate, they can invade, to deliver some of these drugs? So these are some of the, the future perspectives that Olu and our team are taking dealing with some of these diseases. But I just wanted to I wanted to pause for a couple of minutes for people to understand, because I know you're going through a lot of data and a lot of work. So go ahead, please continue.
Yeah. So here I'll continue quickly. So this is just showing that radiation, it does cause DNA double-stranded breaks as we expected. And I just wanted to quickly show the amount of damage that you're seeing. So it does increase it, but then whenever you add vertoporphin, cause an exponential amount more damage. So here on the left, you have these are just chordoma cells that have been treated with either vehicle or vertoporphin. And vertoporphin by itself does not significantly induce DNA double-stranded breaks. But then when you add radiation, so this is just low dose 2-gray radiation, you compare the vehicle to the 2-gray, it's not a huge difference, obviously, but then if you compare no radiation to radiation plus vertoporphin, it does definitely significantly increase the amount of double-stranded DNA breaks. So chordoma cells, they have the ability to repair DNA damage. I mean, all cells do have the ability to repair DNA damage, but for chordoma cells, you see the maximum amount of damage at about 30 minutes, and then it continues to repair that damage. So the vehicle in the blue, that's not true with vertoporphin, but then the red, you can see here with 2 different cell lines that vertoporphin prevents these cells from repairing their DNA, and then over time, it does cause more DNA damage. So that's very important. But now the question is how. So here, and obviously I showed that it does work. It makes these cells more sensitive to radiation, and it causes more DNA double-stranded breaks. But how does it do it? So the 2 theories kind of went into the 2 thought processes I had going into all of this was that it inhibits the DNA damage pathway, and then also that it modulates cell cycle regulation, making the cells more sensitive by placing them in a phase that is more sensitive to radiation. So here, I'm just going to quickly show this, really mainly just to highlight some of the effectors in this DNA damage pathway, ATM, ATR, and H2AX gets phosphorylated into gamma H2AX. And these are some of the early things that you see for the DNA damage pathway. Here, basically just showing, this is a flow cytometry showing that vertoporphin inhibits gamma H2AX expression. So as I mentioned, gamma H2AX is one of the first things that you see in this DNA damage pathway. So it prevents H2AX from being phosphorylated into gamma H2AX. And then here, basically just showing a lot of these different proteins that I mentioned before, ATM, ATR, PARP you don't see here, but PARP is another very important one in this pathway. And also what I also thought was cool is that YAP is more highly expressed when, after radiation damage, which is, it explains why this works. So YAP is connected and tied in with all these radiation DNA damage proteins. So here, I'm not going to spend a lot of time on this, basically just the same thing I showed in the last slide, but in PCR form. So these are all different genes in 2 different cell lines. And here just showing that vertoporphin does inhibit the DNA damage repair genes. So now the next step was to take chordoma cells and knock down YAP and then see what effect that has. So vertoporphin's mechanism of action, as I said, is to inhibit YAP. Now we're taking YAP in the cells and knocking it down. So here, just looking at these are Comet assays, looking at the amount of DNA damage in these cells. So these are with no radiation, and then here with just low dose 2-gray radiation. And you see the cells that have been knocked down with YAP, obviously, definitely a higher amounts of DNA damage. So these cells are more sensitive to radiation, and radiation induces more DNA damage than it would if YAP were present. And the same thing with flow cytometry, basically just showing that the amount of gamma H2AX is decreased. And this I thought was pretty cool. This is basically just showing that YAP decreases proliferation. This is a timed experiment. It's just showing growth over time, a growth curve. So if you look at the empty vector, when you add vertoporphin, obviously very significant, it definitely decreases the amount of growth. But then when you look at the cells that have been knocked down with YAP, and once you add vertoporphin, it doesn't cause a huge change. It's not as significant of a difference when you add vertoporphin. And to me, that means that the main mechanism of action by which vertoporphin is causing its effect is through inhibition of YAP. So this is really more of just a confirmation experiment just to see whether the effects we're seeing are because of YAP inhibition from the drug or from off-target effects. And this also was really cool. So this, the other things I was talking about, that was all related to the to DNA damage repair and that whole pathway. The second thing I mentioned was that I think that it makes these cells more sensitive because it places them in a more sensitive phase of the cell cycle. So G0, the cells pretty much have it's not S and G0 and G1 are not thought to be very sensitive because for G0, the cells do have enough time to repair the DNA. But then when you look at the G2 phase, one of the main thoughts behind why cells are more sensitive in the G2 phase is because they don't have enough time to repair that DNA. So if you look at the empty vector, these are just normal chordoma cells. You look at the distribution of cell number of cells in the different phases. But then if you look at the knockdown cells, you can tell that there's significantly greater amount of cells in the G2M phase, as well as a decreased amount in the G0, G1 phase. And the concept of G2M blockade and G2M being a more sensitive phase has been shown before. So basically, we're just confirming that this is the reason why YAP knockdown does makes these cells more sensitive to radiation. So I'm going to switch gears a little bit here. Now we're going to get more into the chemotherapy component of some of the work I've done. That was all radiation. This is all chemo. So this is a figure from a paper that we previously published. Basically, you can see here a few of the different trials that have been completed in chordoma and some of the different pathways and drugs and targets. This is a beautiful figure that Paula helped me to put together. And this is what I used in terms of deciding what drugs to use for these series of experiments. So basically, I used drugs that have been previously used for chordoma in a clinical trial, but they didn't have a significant effect. And honestly, none of those trials had a very robust effect. So hence why I think this needs to be done. So I'll just quickly talk about some of the drugs. So camptothecin, it's a topoisomerase 1 inhibitor. Imatinib, it's a PDGFR beta inhibitor. And like I said, these are actually, imatinib is probably the most commonly used drug in terms of clinical trials for chordoma. But despite all these trials, it hasn't really been that effective. So afatinib is another one, which does have multiple pathways that it targets. And this is one of the exciting ones. I'm going to show you soon that I think this one does have some promise when combined with vertoporphin. And seraphinib is another one. This is a newer drug, and it has been used for chordoma, but even in the trial, I think only 2 patients had a sustainable response to the treatment. So now, here we're looking at combinations of the drug plus vertoporphin. So here just a growth curve. And the main thing to notice here is the green and purple. You see that when you add vertoporphin to it, it doesn't really cause a huge difference. It doesn't change what camptothecin is already doing, which means it doesn't have much of a synergistic effect. So this didn't seem to me to be the ideal target for a combination therapy. And I mean, the drug, it does kill the cells, but the issue is with camptothecin is it does have a high toxicity. So this would be a drug that if you were able to make it better, I think this one would show a little bit of promise, just because if you can give a really, really tiny dose, I think it could be effective, but it doesn't appear that vertoporphin adds much to that drug already. So here with the imatinib, it does appear to be a little bit of a difference in terms of vertoporphin by itself or imatinib combination, but not really a significant difference there. So then afatinib, this one, I was able to show to shift the IC50. That's basically the amount of drug that you need to cause 50% reduction of cells. I was able to shift the IC50 to the left, which I thought was really exciting. And then also, it appears that it does have a little bit more robust of a response when you combine it. And then similar with the Vertoporphin, the shift with the IC50 wasn't much, but then whenever you look at the combination of the drugs in terms of a growth curve, it did appear that there was at least a little bit of a difference. So the next thing was to, yeah, of course.
And Olu, just very quickly, as you're doing this, before you get into these more complex, this experiment that you just showed right now, just for the audience, which cell lines do you use?
Yeah, that's a good one. So this one, what I'm showing right here is a JHC7. So there's some other data, another cell line, but this is JHC7.
It's just important for, there are only a couple of cell lines that are fully characterized. One of them was by a group of MD Anderson. The other one was the work that we did originally at Johns Hopkins. That's what it's called, JHC7 for Johns Hopkins. That's what we did. But actually, Olu and Paula have also been establishing some potential cell lines from our work here at the Mayo Clinic as well. But then not too many cell lines out there in the world available. Actually, only 2 that are really truly accepted. They have all the characteristics. So, and we're about Europe to show a much more elaborate experiment, obviously.
Yeah, and that's a good point. Chordoma cells, they're hard to grow in culture. I go back to what I said in the very beginning. They're histopathologically benign in terms of how they are in culture and on in pathology after when staining them, but obviously they have very aggressive features. So that's been one of the hindrances in doing more work with these tumors, just because of the lack of cell lines. But as Dr. Q mentioned, hopefully we'll have more coming in the future. So here is really just a combination of all of them. It's a lot of lines, a lot of things going on, but basically just giving you a global picture of what's going on. And then that's kind of going into this. So this is kind of the meat of the whole chemo portion of my project. So these 2 drugs do appear to have some synergy when you combine them with radiation, or combine them with vertoporphin rather. So this is exciting to me. So these were drugs that previously had some effect, but did not have a very robust effect in clinical trials. So my thought is, can we make them better? And it appears that with vertoporphin, you can make them better. And these are pretty low doses of vertoporphin that you can use. So my thought is maybe you can either give it in the tumor or systemically and combine it with these drugs to make them both work much, much better. This is something I'm just going to quickly pass over this, but this was exciting because brachiary, as I mentioned earlier, is upstream of YAP. So I didn't really think that vertoporphin was going to have an effect on brachiary, but here, as you can see, it does. And why that's important is because all chordomas express brachiary. It's one of the pathognomonic features of the tumor. So all of them are going to express this. So if vertoporphin can also affect brachiary, my thought is maybe this could be a potential cure, the closest thing we can have to an actual cure for the disease, but only time will tell. So this is something ongoing right now. So we have a group of tumors that were growing in the flank for 64 of these mice, and we've been delayed a few times, but I think hopefully this week I'll be able to start this experiment where essentially we will treat the mice with either vehicle, with systemic vertoporphin, with a single dose of vertoporphin particles into the flank, or with combination of systemic and intratumoral therapy. And then those groups will be split into a group receiving radiation and a group not receiving radiation. And the goal of this is to see if we can confirm the results that I've shown before, confirm that in animals, which obviously is absolutely necessary to take this to the next level. And I did confirm this using the spine mets data. That is something, as Dr. Q mentioned, I submitted it last night for publication. And in that cell line, those cell lines rather, it works like magic. I mean, it completely kills the tumor, shuts them down, and sensitizes them to radiation. So I'm really excited to see where some of that work is going. And the cool thing about the kind of metastasis data is, so metastasis, it's basically a cascade of different events. So first you have to have the ability to migrate, to spread into the the vasculature, and then to have the ability to leave the vasculature to then deposit in these new sites, and then have to be have the ability to replicate themselves, or clonogenicity. And Vertoporphin effectively shuts down both of those abilities. So it's really exciting for Mets. So I'm excited to see where that's going. But for this, basically it showed here that Vertoporphin, it does have a synergistic effect when combined with radiation. It makes the cells more sensitive to radiation via inhibition of the DNA damage cascade, as well as cell cycle regulation. So two mechanisms there that I'm showing. And then it also has a synergistic effect when it's combined with two of the drugs that I looked at, which are Afatinib and Seraphinib. So hopefully clinical trials in the future can be completed where we can kind of look at this a little bit better. And also I probably should do an experiment where I use Vertoporphin radiation and combine them with these drugs to see what effect that has. And probably that would be something for the R01 that we'll be submitting. So kind of some of my thoughts are, would these results be the same with protons? What we've been using obviously is photon-based radiation. And obviously for chordoma, it's protons that are most commonly used. So this will be something that hopefully we can explore in the future. We'll need to replicate this using an orthotopic model. We do have an orthotopic model that our lab has created, which is the only one. Orthotopic meaning it's the tumor in animals in the location that it would normally be in humans. So these are spine tumors in rats. What I want to do is create a resection model using chordoma and Mets, which is something that our lab has done in the brain. And the other thing I want to do and kind of figure out, I'm not sure how this is going to work, but to find a way to make these particles diffuse through the bone better. Because my thought is, patient, we can I do a percutaneous procedure. Let's say you have a patient with Mets, maybe they don't need surgery, but they're going to get radiation, or maybe they need cement, so you can do a procedure where you can give them cement to help them with their pain, and then also at the same time leave these particles there and then make the radiation work much better and stop the tumor from growing. But to do that, you need to find a way to make these particles diffuse through the bone. So hopefully we have some smart people that I can collaborate with in the future to make that happen. So there's a lot of people that helped with this project, more than even is listed here, but these are some of the primary people that have helped me. So thank you all for your time. I hope I stayed within the time frame. I don't have my clock. So thank you.
You did a beautiful job, a beautiful job. I know there are some questions, and I love the futuristics. I love the issue with protons and carbon. I mean, as we are opening that here, and I know that you're interested in leading some of those efforts in the spine. And the second principle is how to deliver them, the microparticles and nanoparticles. They can be pegylated, of course, and Jordan Green has a lot of intellectual property on that space, but also thinking about how do we use the actual mesenchymal stem cells, as we have talked about it, as mules rather than Trojan horses, and as they can find their way, because they can actually get into areas, they can migrate, they can invade, and they can certainly do it in bone as well, because we know that's actually true in the work that Antonio Forte is doing with this group. You can use them, and as they're moving in, they're delivering. They're dropping off like airplanes from the World War II. They're dropping out their little bombs, which is the Vertoporphin. So something to consider. So I see some questions already. So let's go ahead. The first one that I saw was Dr. Lina Marenko. Lina, and then I'm going to pivot to Ala. Go ahead, Lina.
Hi, Dr. Akinduro. Thank you so much for your talk. It was very interesting. Although it was based on chordoma, I wanted to ask some questions regarding metastasis. it's very interesting what you're saying about how these two, like metastatic cancer cells, respond to verteporfin. My question is, what will be the route of administration? Like, how do you envision administering verteporfin in these patients? That's one. And then the other thing is, there's one type of complication from metastasis, which is leptomeningeal carcinomatosis, that has horrible outcomes. Once the patients are diagnosed, they have just like less than 2 months to live. If it's not like targeted therapy, like osimertinib has good results. But have you, like, what's the CSF penetration of verteporfin? So you could like probably give it via CSF in these patients and see if it regresses also leptomeningeal cancer.
Yeah, excellent questions. So for the first one, so actually in the last experiment that we did in mice, we did a combined systemic and intratumoral therapy with verteporfin, and that one definitely had the best results. So what I envision is you have a patient with Mets, either brain or spine, or maybe they have one solitary Met. So you can give the drug systemically, and then if they do have one Met, maybe they had a recurrence or something, then you can give the tumor, the particles in that systemic or in that one solitary Met. And what I think would happen is it would prevent further metastasis. For the reason that I mentioned, it kind of affects the whole cascade, the metastatic cascade, in multiple different ways, early to prevent migration and also late to prevent growth of that solitary Met. So what I envision is if you have a patient with solitary Met, treat them systemically and then give the particles. So hopefully it shuts down further metastasis as well as prevents growth of that current one. And then for the second part, honestly, I don't have the answer to that because all my work has been with spine. I haven't had to worry about CNS penetration, so I can't really give you a good answer to that. But I will say that obviously to combat that, the particles would be an excellent way if the blood-brain barrier were inhibitive. Because if you're in the, in surgery already, removing this tumor, you can just leave the particles there, and then you don't really have to worry about crossing the blood-brain barrier.
Thank you so much.
Thank you.
Beautiful. Let's go to Dr. Montaser. Ala, go ahead.
Dr. Akinduro, thank you so much, and congratulations for such a great work. Chordomas are one of the pathologies that really needs further research to kind of like help future directions and addressing the optimum treatment for them. I had this comment in mind, and a question you kind of like partly answered it, so the comment's still valid. But the question was, have you noticed, or what are your thoughts about the difference in behavior between skull-based chordomas and spine chordomas? But apparently answering the second part of the last question was that the main focus was spine chordomas. So I think this is could be something to be considered in the future to kind of like see whether there is any changes in the behavior of chordomas between skull-based and spine locations.
Yeah.
Any thoughts?
Yeah, of course. But I will say there have been some studies that have shown that chordomas in the spine, like the sacrum, for example, do behave different than ones in the skull base. So that is something that we know, whether it's via their growth patterns or some of the genetic markers. There are some differences there. But I still think that vertoporphin would work either way. Kind of what I mentioned, how all these tumors have brachiary. So no matter if it's in the skull base, the spine, wherever, soft tissue, doesn't matter. They all have brachiary, so this drug still should work for it. And even in the skull base, though, you won't really have to worry about the blood-brain barrier as much. So, and it should still, if it works in the spine, it's still bone. It should work in the skull base because it's also bone as far as the systemic therapy. And then hopefully in the future, like I said, we could find a way to find some sort of particles or develop some sort of particles that can diffuse well through the bone. So that's kind of, next step, next level.
Thank you.
Beautiful. Let's go to Dr. Mead and then JP.
Hi, good morning. This is more so like a comment. I just wanted to say congratulations, Olu, because this work usually takes like a year or two, at least 2 years for people to develop. And Olu has worked like full speed 2 projects and really getting a lot of results, and it's great learning from you, Olu. So I just wanted to say that that working with you is amazing, and so congratulations.
Oh, thank you.
I would go a step further. I would say that this work takes 10 years, and it wasn't done until Olu, with your help, Paola, and the help of Paolo Schiaparelli, really took to the next level. I mean, obviously, it was 10 years in the making. It was really not going anywhere meaningful. Sagar and Juan Carlos tried to start. The good thing they did, they established a cell line, with Ahmed at the time. But the reality is that it's taken 10 years, and really in less than a year, with all of you guys, have taken it to the next level. So congratulations.
Yeah, we were impressed. He came in, he dominated 2 papers. It's amazing. Thank you. Congratulations, Olu.
Thank you so much.
And sufficient to mention that he submitted that paper. I'll say it because, so that way people are to sell reports last night. I don't know if he'll get in, but it's obviously a very powerful type of work.
Yeah, thank you.
Right.
Well, there's no way I would have been able to do all of this without, all the help of everyone in the lab, honestly. Paola has been extremely instrumental, and McKinley as well, in helping me get some of these things off the ground. So thank you.
Yes, and I always tell people that, remember, a horse is only as good as his jockey. So we had an amazing jockey to be able to, get this to a championship. So we'll go one more last question coming from JP, and then we're going to wrap it up to say 12 already. Go ahead, JP.
Hi, Olu. Dr. Akinduro, beautiful work and a fantastic, collaboration. Great to see your presentation. Olu, it is interesting. I think like GBM's chordomas as well, like we mentioned all of them in a single group, like under the name of chordomas. But I think as we move on, like we start to understand more and more about the, potential of different subtypes, not only about skull base and spine, but also within, a single location itself. Last year, we had collaborated with the group in Toronto, looking at the methylation profiles and subtypes. And so I wonder if you, and then we kind of have an idea that there are at least 2 subgroups of chordomas that we could overall classify. But I wonder if looking at your experiments, what you've seen, you also, foresee that the impact of your experiments may be impacted by the subgroups within different types of chordomas, and if you're planning in the future to consider those types of subgroups of chordomas into your models.
Yeah, so I assume you're referring to the dedifferentiated subtype versus the regular kind.
No, that's I do agree. Like that's the classic, division. Like what we did in collaboration with Zadi's group in Toronto is actually it's Jeffrey Zucato's main work. We looked at the methylation profiler, and we divided. We were looking with different groups into different methylation signatures. So epigenetics classification of those tumors to try to move into the classic chordoma and looking into different subtypes. Because what we started to see is that for the spine classic or conventional chordomas, you guys in spine oncology can get a beautiful in-block resection. And those are the tumors that end up getting metastases after 10 years, and they end up dying of mets. While the skull-based ones, they, because of the location, we cannot get in-block resection. And it's almost like if the natural history, so to say, would be different. And then we started to look at the different subtypes. And it seems that maybe even within the classic, 2 different groups of chordomas that may have a different response to radiation. So long story short, it seems to us that there might be 2, more than what we see in terms of signatures of chordomas. And I wonder if that should be something that we could and should be looking into our models in the future.
That's a great point. It actually makes me think maybe that's something we can, can add for some of our future work and future, our own submissions, just because I don't have a good understanding of that. I don't think many people do, but, we're learning more about the different genes that are involved besides just what we know, which is brachiary. So the only way to answer that would be to collect more cell lines and to do more work. So, some of the things we're doing in the operating room, collecting these tissues is important, because I think the only way to answer that question will be with time and more cell lines.
Yeah, I think just bringing on what Dr. Q always mentioned to us. I mean, as I was listening to your presentation, I was thinking, well, maybe that's a good point for collaboration. He had given the mission to get more people to join us as visiting people. And I was thinking, well, maybe it's time to get Dr. Zadi and also Danielle de Carvalho, who was doing actually in that paper. We did some liquid biopsy, I mean, not liquid biopsy per se, but we were looking at, circulating markers. And maybe that could fit well into the projects that you're developing as well. So maybe a good opportunity to collaborate.
Yeah, I love it. Let's talk offline about that.
Sure, absolutely.
Beautiful. I love it. Use the operating room as an extension of the lab and everybody's going to win. But the most important is that the patient and their families, all of us will win because all of us are patients, not only as physicians and scientists, but also at one point in our lives, we are patients that will benefit from this therapy. So, well, we can continue to go on for the rest of the morning, but I know the residents have the residency education day. Olu, I will be meeting with you guys virtually later. Vanessa setting up our regular day. We also have the celebration, by the way, which was not announced here, but Dr. Dean is retired, and I know Delia is putting something really nice. Linda, do you want to maybe mention a few things because some people may be up there on the clinic?
Yes, so
Linda.
Dr.
Yeah, go ahead, Linda.
Oh, yep. So we're having something in Megarian 4110 here today. So if you can come by at your leisure, feel free to stop by. We're going to have some lunch and just some nice words to send him off in his retirement if you can make it.
Beautiful. So good. Excellent. Olu, great work. Great plans. Everybody have a great week. We'll see everybody Friday. Have a wonderful week. And thank you, Gabriel, all the way from Bucaramanga, also joining us. And I saw your comments. Beautiful work.
Yeah,
right?
Beautiful portfolio. Thank you.
Take care, everybody. Bye-bye.